All right, we're going to talk about thrombophilias today. Very high yield topic. We're going to go through all like the pathophysiology and the management. And we'll go through like some of the like step one pathophys and physiology as well. Really high yield. We'll go through a lot of the big ones. So we'll talk about the clotting cascade, the coagulation tests. I'm not really going to cover platelets here because that deserves to be its own lecture, which I'll do in the future. We're going to cover factor V Leiden, prothrombin, antiphospholipid, PNH, HIT, antithrombin 3, protein C and S deficiency, and elevated homocysteine levels via both inherited and acquired. And then we'll do putting it all together. Thrombophilias are definitely one of my more favorite topics. I feel like I say that for every lecture because it's true, because I love it all. But it's a really high yield, and it's fun to talk about if you understand the physiology pathophys. So this was the question I posed on Instagram the other day. So which of the following is the most common cause of thrombophilia? We have the prothrombin gene mutation, factor V Leiden, antiphospholipid, PNH. So if you didn't get a chance to try to answer this, pause your screen and think about it. So the most common thrombophilia is factor V Leiden. The reason I asked this question, right, this is like a really like one sentence, right, really straightforward. I've seen them ask questions, the MBME, they'll give you a patient, like a really vague vignette, a patient with history of clotting. They have a family history of clotting. They don't give you anything to push you one way or the other. And we'll talk about some things that would push me one way or the other in all of these diseases listed. And they're just like, which of the following is the likely cause? And it would be like 4 or 5 options. And you're like, well, how the hell am I supposed to answer this? They want you to know the epidemiology. So factor V Leiden is the most common inherited thrombophilia. So just based on like statistics, this patient likely has factor V Leiden. That's the way they want you to answer those questions. All right. So let's talk about the clotting cascade because it's really going to be the backbone of everything that we're going to talk about moving forward. So what is the purpose of the clotting cascade? Well, it prevents blood loss following any kind of vascular injury. And our end goal is to convert fibrinogen to fibrin to form that stable clot. So that's done by thrombin. Thrombin is going to convert fibrinogen to fibrin. Fibrin is kind of like the meshwork that holds my clot together. Okay. There's 3 kind of key phases. There's our initiation phase, which is really our extrinsic pathway, and that's going to be a rapid response to trauma. There's going to be the amplification phase, which is really run by the intrinsic pathway, and that's going to sustain and strengthen our clot formation. Then there's the propagation phase, our common pathway, which is going to help form that final fibrin that's going to form that meshwork to keep my clot together. So why it matters? Well, in certain bleeding disorders, which I'm not covering today, right? That'll be its own lecture, like hemophilias, then we really need to consider, okay, where's the abnormality in my clotting cascade? And then what is kind of the implication of this, right? If my patient doesn't have factor VIII, like in hemophilia, we don't have a fully functioning clotting cascade. It's going to be really hard for us to make clots, and the patient will have a lot of bleeds, right? We'll talk about that separately. Today, we're really focusing on the thrombophilias. Well, what if they have overactivation of this clotting cascade? Or what if we're missing inhibitors of the clotting cascade? So my clotting cascade works too well, right? Now we're at risk of clots, right? And that can be extremely devastating too, right? Think about clots in the brain, ischemic stroke, clots in the lungs, PE, clots to the kidney, we get renal artery stenosis and potentially kidney damage, right? Clots in the heart, right? We get MIs, right? We can think about every organ getting a clot. Very bad. So there are certain anticoagulant targets that we commonly will approach with management. Heparin is going to activate antithrombin 3. Antithrombin will inhibit thrombin and factor X, which I'm going to show you in the next slide. Warfarin is going to block vitamin K dependent factors. So those are 2, 7, 9, and 10. Warfarin also blocks protein C and S. So remember, warfarin's job, right? We have this epoxide reductase that sits in the liver. The epoxide reductase takes vitamin K and it reduces vitamin K. And that reduced vitamin K is a really important activating factor for coagulating factors 2, 7, 9, 10, and protein C and S. Warfarin blocks that vitamin K epoxide reductase, VQuark, okay? So by blocking it, we're never able to make reduced vitamin K. So we're not able to make fully functioning proteins 2, 7, 9, and 10, okay? There are DOACs. These are the newer drugs which directly inhibit factor X or thrombin. All right, so looking at like everything I just told you, now let's see how things work, right? Our intrinsic pathway is going to be factor 12, then 11, then 9, and 8, and 9 and 8 like to work together. Okay, we test this with the PTT. So the way I remembered it right is intrinsic PTT. So PIT, like think about like Pittsburgh. Um, there's the extrinsic pathway, which is starts with this tissue factor, which is also sometimes called factor 3, and then it activates factor 7. Okay, and that's looked at with our PT and our INR. So again, PT and extrinsic PET. And then our common pathways. So both the intrinsic and extrinsic pathways converge upon factor 10, and then it goes 10, 5, 2, which is prothrombin, and then 1, which is fibrinogen. And then that's we can look at the PT and the PTT. So again, the intrinsic pathway is 12, 11, 9 plus 8. The extrinsic pathway is factor 7 activated by factor 3. And then they both converge on 10, the common pathway, and then it's 10, 5, 2, 1. Okay. So again, here's a mnemonic for you, the tenet, 12, 11, 9, 8, 10, which will 10 puts us at the common pathway. And then the end goal is to get thrombin, factor 2A, which will convert fibrinogen to fibrin. The fibrin mesh stabilizes the platelet plug. Really just you have to just practice the clotting cascade. If you're like a new M1 and you've never seen this before, just practice, put it on an Anki card. I'm not a huge fan of Anki, but this would be one instance where Anki would really work. Draw it out as many times as you want. I also think like Ninja Nerd, I think had a good video that maybe I watched as a first year. Really just practice. My goal of today's lecture is to not like go crazy on the clotting cascade. I think we've already covered it more than enough, right? I really want to talk about the diseases that they're going to test you on the exams. So the regulation of the clotting cascade, this is really important. There's key anticoagulation mechanisms. Antithrombin 3 is going to inhibit thrombin and factor 10, okay? This is enhanced by heparin, right? Heparin's job is it activates or it enhances antithrombin 3. Antithrombin 3 then inhibits thrombin and factor 10. So that's why heparin is a really good anticoagulant, because we will activate antithrombin 3 and we will inhibit thrombin and factor 10. And as we just saw on the last slide, that's going to cause a real problem making those fibrin nets, like those fibrin nets, and therefore our blood is going to not be able to form these nice big clots, right? That's the whole purpose of heparin, all right? There's the protein C and S system. So protein C is activated by this thrombin thrombomodulin complex, and it inactivates factors 8 and 5, okay? Super important here. Protein C will kind of do more or less the same, protein S. Protein C gets all the limelight because protein C, we have a deficiency, like a known inherited deficiency of protein C. But really, these guys' job, it's to shut down factor 5 and factor 8. So again, if we don't have protein C and S, we're not able to shut down factor 5 and factor 8 as efficiently, and my clotting cascade just keeps moving and moving and moving. We've taken away the brake pedal. There's something called tissue factor pathway inhibitor, which inhibits the extrinsic pathway too. So that'll stop the tissue factor 7 complex. All right. So the clinical relevance here, right? Heparin resistance. So what if I give a patient heparin, and remember, what do I look for when I give a patient heparin? Do I look at the intrinsic pathway? Do I look at the extrinsic pathway? So am I looking at the PTT or the PT? So we normally look at the PTT, right? I had that on this slide, or I had it on some slide here. Heparin activates antithrombin, and we're going to look for the PTT, right? Well, that's the way we track heparin. So if I give my patient heparin and it's still not working, like the PTT is not prolonged, we should think about an antithrombin 3 deficiency. All right, that's because heparin activates antithrombin 3. So if the patient doesn't have antithrombin 3, there's nothing to activate, right? I think a really good example of this and an acquired antithrombin 3 deficiency would be something like nephrotic syndrome. I'll do a whole lecture on nephrotic syndrome because that deserves its own too. But remember, in nephrotic syndrome, we get damage to the podocytes and the glomerular basement membrane. We lose protein through the urine. We classically lose all of this albumin, right? So the patient loses their oncotic pressure. They can get really puffy eyes. They can get ascites, puffy legs. But we can also lose antithrombin 3 through the urine. So the patient is put in a hypercoagulable state because antithrombin 3 normally inhibits thrombin and factor 10. We can also lose immunoglobulin. So the patient's more prone to infections, right? And when your body senses very low albumin levels, your liver is going to try to pump out a ton of just literally anything to try to make more oncotic pressure, right? So at first, the liver is going to compensate by increasing the production of albumin. But at some point, the liver's not able to make any more albumin because we're just peeing it all out, right? And the liver poops out. So the liver will eventually like switch to a different option, and it tries to throw out all of these lipoproteins, right? And so our lipoproteins are make up the backbone of our cholesterol. So you might see the patient's cholesterol is pretty high in nephrotic syndrome due to this mechanism. Nephrotic syndrome, again, will be its own lecture. That was just a brief glimpse. We have something called warfarin-induced skin necrosis that's due to a protein C deficiency. So whenever I give the patient warfarin, if I forget to bridge them with heparin, right, warfarin, again, it works on factors 2, 7, 9, 10, protein C and protein S, right? Remember, those are all made in the or like activated in the liver via vitamin K. If the patient has underlying protein C deficiency, this becomes a problem if I don't bridge them with heparin because warfarin's job, it will reduce 2, 7, 9, 10 and CNS. And CNS have the lowest half-life out of all of those options I just said. 2, 7, 9, 10 CNS. CNS have the lowest half-life. So warfarin is going to work on CNS right away. This patient already has a low protein C level. Warfarin is going to take out any rest of it and take out protein S, right? And so what did I tell you protein C and protein S do? They inhibit factor 5 and factor 8. So the problem happens is we give the patient warfarin and we forget to give them heparin with it to bridge. We lose protein C and protein S, and we were already at a deficiency. So now the patient is in a really hypercoagulable state, and they could get these massive like purpura and hemorrhagic lesions from all this massive clotting that's going on. All right. There are some really good pictures if you look up like warfarin-induced skin necrosis online. So we get these massive clots that cut off blood supply to the skin, and then we get these massive lesions like purpura. Sometimes they're called purpura fulminans. Okay. Factor 5 Leiden. Factor 5 Leiden we're going to talk about, so I'm going to skip for now. And then liver disease or vitamin K deficiency, right? So I did a lecture on liver disease versus DIC where I talk about the pathophys in depth on that lecture. So go watch that one. But basically, if the patient has liver disease, we can't make all of my clotting factors except for factor 8, which is made outside of the liver. Or if the patient has vitamin K deficiency, either they're not eating vitamin K, right, in leafy green vegetables, or they have fat malabsorption. So remember, my fat soluble vitamins are A, D, E, and K. They're reabsorbed in the terminal ileum. So maybe my patient has some problem with bile that helps us reabsorb fats. They have some problem with lipase made from the pancreas that helps us reabsorb fats. They have some sort of damage to the terminal ileum or other parts of the colon or the small intestine that are leading up to the ileum. And so there's fat malabsorption, right? We could name like a ton of diseases, right? Like the biggest ones for GI would be like Crohn's and celiacs, right? They're not going to have enough vitamin K in your system to be reduced to then activate 2, 7, 9, 10 protein CNS. All right. So hopefully all this is making sense. So just to interpret the labs, here is actually, this was my heparin slide that I was looking for. So when I look at the PT, remember it tells me my extrinsic pathway. We use it to monitor warfarin and we use it in liver disease, right? INR is a good function. It tells me what is like my manufacturing capability of my liver, right? Is my liver able to manufacture these coagulation factors, right? That tells me it's a very good underlying sense of how well my liver is doing. If my PT and my RNR start to rise and rise and rise, that tells me, man, it's taking forever for my blood to clot. That means I must have a deficiency in my clotting factors, right? If the patient has underlying liver disease, we can already try to figure out why. Well, we're missing 2, 7, 9, 10 and protein C and protein S. For the PTT, right, that's measures our intrinsic, so 12, 11, 9, 9 plus 8, and the common pathway, right? So we use this in heparin monitoring, in hemophilia A and B, and in antiphospholipid syndrome. We'll talk about antiphospholipid syndrome coming up. The thrombin time, that was really our last step, right? So that's converting fibrinogen to fibrin, because thrombin is a thing that cuts up fibrinogen to make it into fibrin, right? And remember, fibrinogen is made in the liver. So this is really good if we have suspected DIC or heparin overdose, right? I talk all about DIC in a couple of different lectures. There's a liver versus DIC lecture, and I talk about it in the MAHA lecture. So go watch those. Mixing studies are really important because they help us distinguish a factor deficiency from an inhibitor, right? So let's say my patient has hemophilia A, okay? They're missing factor VIII. All I need to do, right? So if I'm missing factor VIII, right, my PTT will be elevated, right? Because factor VIII is part of my intrinsic pathway. So 12, 11, 9 plus 8, and then 10, 5, 2, 1. So if I'm missing factor VIII, my PTT will be elevated because it takes the patient a really long time to make that clot. If they're just missing factor VIII, okay, and I give them normal plasma that has factor VIII in it, it completely reverses the abnormal PTT, right? Because now when I do the retest with the normal plasma, they've got the factor VIII and everything's able to go hunky dory, right? Everything's perfect, all right? The problem is if my patient, I do the mixing study and they have persistent elevation, so their PTT did not correct, then I need to think about antiphospholipid syndrome or an inhibitor. We'll talk about antiphospholipid syndrome, so I'll explain that why. But if the patient, let's say, has hemophilia A secondary to an acquired inhibitor, and again, I'll talk about this more in my bleeding lecture, but we can get, any normal person can get antibodies to factor VIII, okay, which can cause an acquired hemophilia A. The problem is, let's say the patient has that, right? Their PTT is elevated. They have this acquired antibody to factor VIII, but we don't know it yet, right? We took their blood. We see the PTT is elevated. I now mix it with normal plasma that has normal factor VIII. The problem is we did nothing to get rid of this antibody. So that antibody is still going to attack any more factor VIII we give them, right? And so therefore the PTT is not going to correct on this mixing study. So whenever I see a mixing study that doesn't correct, I usually think about some sort of inhibitor, and antiphospholipid syndrome falls into that category. Then there's the D-dimer, right, which is a fibrin degradation product. So whenever I see elevated D-dimer, I just think about fibrins being chewed up, which tells me a lot of clots are being put down. We can see this elevated in DIC. It can be elevated in PE or DVTs, right? So again, an elevated PT and a normal PTT, I think about a factor VII deficiency, early warfarin effect, or early liver disease. That's because I told you 2, 7, 9, 10, C and S, right, are all liver and vitamin K, right? C and S have the lowest or the quickest half-life, so they're the first impacted. But then when I think about my factors 2, 7, 9, 10, the factor VII has the quickest half-life out of those factors. So really the first thing that gets impacted in liver disease or warfarin use other than protein CNS is factor VII. So my PT rises before my PTT does, okay? If my PTT is elevated and I have a normal PT, well, then we got to think about our intrinsic pathway, right? So our hemophilias, my antiphospholipid syndrome, and my heparin use. If both the PT and the PTT are elevated, now we need to think about DIC, advanced liver disease, or super therapeutic anticoagulation. We gave them too much heparin. We gave them too much warfarin. If the mixing study corrects, remember I told you that's likely a factor deficiency. We gave them what they were missing, and now we're back to normal. If the mixing study fails to correct, we should think about an inhibitor, like anti-factor VIII or antiphospholipid syndrome. I did, again, watch my lectures on DIC. That will probably help clear up a lot of things if you don't remember what DIC is about. All right, last thing before we jump into the diseases quick, we got to think about Virchow's triad, right? Virchow's triad is the classic thing that sets up hypercoagulation or this clotted cascade, right? So we're in a hypercoagulable state. What do I mean by a hypercoagulable state? Things like malignancy. So malignancy stimulate my immune response. It causes endothelial cell damage, puts me into a hypercoagulable state. Estrogen puts us into a hypercoagulable state. So a patient who's pregnant, was recently pregnant, they're on OCPs, right? It upregulates clotting factor production in the liver. A patient who's been sitting for a very long time or immobilized puts me in a hypercoagulable state due to venous stasis. Smoking puts us in a hypercoagulable state due to endothelial cell damage. Diabetes causes endothelial cell damage, right? We could go on and on and on. But whenever I'm thinking about clotting factor problems, I always think about Virchow's triad, right? Is this patient in an underlying hypercoagulable state for X, Y, or Z? Do they have underlying endothelial cell damage from smoking, from diabetes, from some sort of underlying injury? Do they have venous stasis, right? Have they been sitting for a while? Did they just have surgery and they can't move, or things like that, right? That's the way I kind of think about it because it sets up. If I understand that and I understand the key pathophys, we can try to get to the end diagnosis a lot quicker and understand the workup and the management. All right. So we're briefly going to go through these. I would recommend, I'm going to see if I can try to start uploading these lectures with the video. I don't quite know how to do that. I'll see if I can figure it out. But for now, like I would recommend like taking a screenshot of each of these. Um, so you have them on your own. But I'll keep working on trying to upload the lectures. So history, what might key me in on factor V Leiden? They might present with a DVT, a PE, especially in like a young adult with no risk factors, right? They might have a family history of it, right? They might have this recurrent pregnancy loss. So when we think about like these hypercoagulable states, the thrombophilias, these thrombus can clot the like placental vessels, right? And so now the baby, the fetus is not able to get the proper blood supply, right? And that can lead to early fetal loss. The risk will increase with OCP use, smoking, and immobility. Exactly what I talked about. So remember, factor V Leiden is the most common thrombophilia. They'll give you a patient who has like there'll be like a 20-year-old female, perfectly healthy. Maybe they just started an OCP and that was kind of the thing that kind of set it off. They have a DVT or they have a PE, and they'll tell you like mom has a history of two PEs, right? And that's now I'm like, that's kind of weird, right? We need to look into it. So labs, they should have a normal PT and PTT. Okay. Their activated protein C resistance might be positive. Okay. And then their genetic testing, right? We'll see this arginine 506 to guanine or glutamine, sorry, mutation in the factor V gene. You do not need to know this for USMLE step 1 or step 2. This is just for your own information. Um, the pathophysiology, this really gets into like the nuts and bolts of why this is happening. It's usually an autosomal dominant. And what happens is we have this point mutation where we change arginine with glutamine at position 506. What happens is normally I told you factor or protein C inhibits factor 5 and factor 8. We have now caused this point mutation where factor 5 gives a big old middle finger to protein C. It's like you can't stop me. Okay. This mutation makes it invincible to protein C. And so now protein C has no way to stop factor V. And factor V just keeps the whole train going, right? 10, 5, 2, 1. We just keep making more and more thrombin, keep making more and more fibrin, and we keep making more and more clots. All right. Um, so again, this is the most common inherited thrombophilia. Management, we're going to avoid risk factors. We can put them on prophylactic anticoagulation. If it's an acute thrombotic event, right, we just treat them like we would standard, right, heparin. We can bridge that over to warfarin or DOAC. We can consider long-term anticoagulation. So again, just my really common, like high yield points. It's the most common cause of thrombophilia. They'll have normal coagulation tests. They have an increased risk of venous, but not arterial thrombosis. Homozygous will increase your risk versus heterozygous. And then it's an important consideration when I see a young patient with stroke, unexplained DVT, pregnancy loss, PE, MI, things like that. One thing I did not talk in this lecture, so I'm just going to mention now, I've seen questions on it where the patient will have a PE, a DVT, an MI, a stroke, some sort of like clotting event, and they will literally have no risk factors, right? I'll just give you like they have a stroke, right? They have a stroke, but they have no risk factors, right? They're young, they're relatively healthy, they weren't immobilized, they weren't doing any of the things, they're not on OCPs, they don't smoke, right? And they'll be like, what's the next best step, right? Once we treat their underlying problem, whether it be a PE, a stroke, whatever. When they ask things like that, and you're like, they have no history of thrombophilia, they have no risk factors for being hypercoagulable. What do I do here, right? NBME is wanting you to think about malignancy, all right? Oftentimes, like malignancies go unnoticed until they become noticed, right? Until like something bad happens. Remember, malignancies put us in a hypercoagulable state because of all this inflammation can cause endothelial cell damage, right? And puts us into this hypercoagulable state. So oftentimes there'll be like a 45-year-old, relatively healthy female, all of a sudden has a PE out of nowhere or a stroke out of nowhere. And you're like, what the heck? You should check for family history of clotting, right? If this is the concept they're testing, they won't have any history of family history of clotting. The next best thing you should do is age appropriate cancer screening, right? 45-year-old female, we would probably do like a mammogram and a colonoscopy. All right. Hopefully that makes sense. I don't talk about that elsewhere, so I just wanted to mention that. Now, our prothrombin, Same idea. It's often asymptomatic until it's not, right? Presents with venous thromboembolism. They may have this family history of thrombosis. Again, recurrent pregnancy loss due to thrombus in the placental vessels. And then it's often discovered during evaluation of an unprovoked VTE, right? Again, you have this patient relatively young, comes in with venous thromboembolism, either in the DVTs or in the pulmonary embolism, something like that. And you're like, why? And you need to further work them up. You send them to the hematologist. They'll do this beautiful workup of all the genetic causes. Again, normal PT and PTT, the genetic mutation will show that mutation in the 3' untranslated region of the prothrombin gene. And this leads to increased prothrombin levels, right? If we have too much prothrombin, we're now able to cut more prothrombin into thrombin, and then more thrombin will cut fibrinogen into fibrin, and we're able to make more clots. All right. So again, the pathophys, I literally just explained that it's autosomal dominant. We switch out a guanine for an adenosine at nucleotide 20210 in the 3' untranslated region. This mutation causes increased mRNA stability. So we're able to make more of this prothrombin gene, right? Factor 2. Increased prothrombin increases thrombin generation, and it puts us into that hypercoagulable state. It increases the risk of venous thrombosis. Again, management going to be the same for everything, so I don't really need to repeat it. Limit the risk factors, give them anticoagulation, consider long-term anticoagulation. So the high yield point, this is the second most common inherited thrombophilia after factor V Leiden. It's a mutation in this non-coding 3' untranslated region. It does not alter our normal coagulation studies. It's associated with an increased prothrombin levels, and then the risk is significantly elevated with a combination of other things that would make me hypercoagulable: OCPs, smoking, immobilization, and underlying cancer, X, Y, or Z. All right. Antiphospholipid syndrome. Antiphospholipid syndrome is one of my favorite diseases to talk about and like quiz my students on because it makes for great test questions. So history, we're going to see recurrent venous and arterial thromboses, DVT, stroke, TIA. History, we'll classically see like recurrent pregnancy loss, especially greater than 3 in the consecutive first trimester losses, or fetal death after 10 weeks, or premature birth less than 34 weeks. So again, the recurrent pregnancy loss, 3 or more consecutive first trimester losses, fetal death after 10 weeks, or a premature birth less than 34 weeks. This may be a primary disease, or it loves to run with lupus, okay? But that doesn't mean every patient with lupus has APLS, and it doesn't mean every patient with APLS has lupus. It can be, APLS can be its own thing, lupus can be its own thing, or they can run together. I usually see in questions, they like to give you a patient who they'll hint at has lupus. They'll give you some sort of facial rash, photosensitivity, pancytopenia, right? I'll do a whole lecture on lupus. That is my favorite disease to discuss of all time. But that's just something that might push me in the direction of APLS. Other features, you might see the livedo reticularis, which what other disease do I classically see that in? There's actually 2 that come to mind. So there's polyarteritis nodosa and then cholesterol embolization syndrome, right? Polyarteritis nodosa, we get damage, we get inflammation of the medium vessels in my legs, which can lead to livedo reticularis. We then, in cholesterol embolization, I have shot off cholesterol from my heart, maybe after a procedure, if we're doing some sort of like cardiac procedure, and they can get stuck in the small vessels and cause inflammation and thrombosis. And then in APLS, it's the same thing, right? Thrombi forming, cutting off blood flow to some of these medium vessels in my legs, leading to this reticular pattern in the legs on the skin. We could see thrombocytopenia. The thrombocytopenia is usually secondary to lupus or ITP. ITP loves to run with lupus as well. Story for another day. You might see migraine, you might see heart valve disease, you might see adrenal hemorrhage as well. So to diagnose it, we need one or more clinical and 1 or more lab criterion persistent on 2 occasions 12 weeks apart. So the patient comes to you, they come to your clinic, you find 1 clinical and 1 lab criterion, they go home, they come back to you in 12 weeks, you find 2 lab criterion, 2 clinical criterion, boom, we've got our diagnosis, okay? So some of them, right, the clinical would be DVT, stroke, TIA, and then the recurrent pregnancy losses, right? The laboratory would be a lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein. Those are my 3 antiphospholipids. Lupus anticoagulant will cause a prolonged PTT that does not correct with mixing study, which I'll talk about in a second, right? So the pathophysiology, actually, and I forgot to mention, you may see a possible false positive VDRL or RPR, which are the non-treponemal tests for syphilis. That's because classically anticardiolipin can cause a false positive VDRL or RPR. That's why whenever we get a positive VDRL or RPR, we always reflex it to an FTA antibody test, right? Which is the more specific treponemal test. And that's usually right if the patient doesn't actually have syphilis, it'll be negative. Okay. They like to throw this into questions. They'll give you the positive VRDL, RPR while they're giving you a vignette on APLS because it just further confirms this diagnosis. Um, Pathophysiology, we get autoantibodies against phospholipid binding proteins. That causes endothelial injury, platelet activation, and complement activation. This leads to a hypercoagulable state, and then it's associated with this catastrophic antiphospholipid syndrome, which is multi-organ failure due to widespread thromboses. Um, the weird thing about antiphospholipid syndrome is with this lupus anticoagulant that prolongs the PTT. So if you're thinking about it, you're like, hey, wait, the PTT is prolonged. So shouldn't my patient be bleeding out, right? Because when I think about a long PTT, it means it's taken my clotting factors a whole lot of time to make this clot. So shouldn't they be hemorrhaging rather than like stroking out, right? Or having PEs or DVTs? The thing is in vivo, like so in our bodies, these guys, these three guys, lupus anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein, they cause this endothelial injury, platelet activation, and complement activation, leading to thrombosis. The problem is when I do my test tube test, my in vitro test, we use phospholipids in the PTT test, okay? So if I'm using phospholipids in the PTT test, guess what? These are antiphospholipid antibodies. So when I add the patient's blood to it, these antiphospholipid antibodies do exactly what they're supposed to do, and they block these phospholipids. And phospholipids are really important to kick off this PTT test, and so it prolongs the PTT in vitro. Okay, so the PTT is prolonged in vitro because these antiphospholipids are blocking the phospholipids that are really important for this test to work appropriately. But in our body, basically the anticardiolipin, lupus anticoagulant, and anti-beta 2 glycoprotein will cause endothelial cell damage, platelet activation, and complement activation, leading to a hypercoagulable state and thrombosis. So the key thing I always teach my students is if you ever seen a stem, the patient has some sort of thrombosis, whether it be stroke, DVT, PE, TIA, X, Y, or Z, but their PTT is elevated really for the sake of USMLE step 1 and step 2, it's going to be antiphospholipid syndrome. Okay. I'm sure maybe like a hematologist out there knows about some other disease that might do similar for the sake of USMLE step 1 or step 2. If you see thrombosis, but an elevated PTT, really that's weird, that's paradoxical, you should think about antiphospholipid syndrome. So for acute thrombosis, we do heparin followed by warfarin. We look for an INR of 2 to 3. We'll put them on lifelong anticoagulation. Really important for USMLE step 2. If you have a pregnant woman who has known antiphospholipid syndrome, we start them on low molecular weight heparin and then low dose aspirin. Okay, really important. Pregnant women, especially for USMLE step 2, pregnant women with APLS, low molecular weight heparin plus aspirin. We usually avoid DOACs for high-risk patients, especially if they're triple positive. They have all three. That's because DOACs have never been proven effective in these patients. For catastrophic antiphospholipid syndrome, we'll do high-dose steroids, plasma exchange, anticoagulation, and IVIG. That is the truest medical emergency, right? We have to act now. So high yield points, it can cause both arterial and venous thromboses. It has this prolonged PTT, and again, it won't correct because the patient's body has these antiphospholipids in it, right? Their plasma has these antiphospholipids in it. So if I take out the patient's blood, which has antiphospholipids in it. If I mix normal plasma with it, it doesn't matter. I haven't removed the abnormal antiphospholipids, so they're still going to do their job and prolong the PTT, right? If this were due again to like some sort of deficiency, and then I mix the plasma, again, that would fix the hole. It would fill the hole that we were missing and fix the PTT. In this case, the PTT is prolonged because of these antiphospholipids that are messing with my in vitro test. So me giving normal plasma on top of it is not going to do anything. The inhibitor is still there. This is a major cause of recurrent miscarriage. Again, another like key thing that will key me in on antiphospholipid syndrome is they'll give me a vignette where the patient has had like 2 miscarriages, right? I should immediately be thinking about antiphospholipid syndrome. It's not related to lupus, but they do commonly exist. And then we should evaluate all young patients with DVT or for antiphospholipid syndrome, especially if they have no clear risk factors. All right. PNH, another favorite of mine, you get these classic triad of hemolytic anemia, pancytopenia, and thromboses. We classically will see this dark colored urine, especially in the morning, due to this nocturnal hemoglobinuria, which I'll explain in a second. The patients could have fatigue and dyspnea and abdominal pain, and they usually have these thromboses in like really weird sites. Like you could have it in the hepatic vein, which is called Budd-Chiari syndrome. You could have it in the portal venous system or the cerebral veins, like really odd places. It may present with aplastic anemia, renal dysfunction, or smooth muscle dystonia. Really, I'm looking for like a male. There's classically males. It could be females too, right? A male in like their 30s, 40s, or 50s with hemolytic anemia, pancytopenia, a weird thrombosis, and then classically like peeing out red stuff early in the morning. And we'll talk about why. So the labs, classically the hemolytic anemia labs, go watch my MAHA lecture. I explain all about this, and I will do a separate lecture on hemolytic anemia where I will recover PNH too. We'll see elevated LDH, low haptoglobin, elevated indirect hyperbilirubinemia, and I explain all that in my MAHA lecture. So go watch that because I explain the why behind it. Hemoglobinuria, especially early in the morning, on flow cytometry, we'll see an absence of CD55 and CD59 on the red blood cells. We may see pancytopenia if the marrow failure is present. And then it's a negative Coombs test, right? This is not an autoimmune driven process. It's not an autoimmune hemolytic anemia. And again, when I do my hemolytic anemia lecture, we'll discuss that why. So the pathophysiology will kind of clear up everything. Like, why is all this happening? We get this acquired PIGA gene mutation in all of my hematopoietic stem cells. This leads to a deficiency in my GPI anchored proteins like CD55 and CD59. CD55 and CD59 are some of my complement inhibitor proteins, right? So if I lose those proteins, there's no longer a stop sign on my cells saying, hey, complement, don't kill me, right? So now we lose the complement, the protection from the complement, and our complement system is going to attack my hematopoietic cells, right? And we get intravascular hemolysis. We can see this nocturnal hemolysis because it's triggered when the patient goes to sleep. When we sleep, we get a little more acidotic, okay? When we're a little more acidotic, it stimulates complement activity even more. It leads to further intravascular hemolysis. The free hemoglobin is filtered by the kidney and it waits in the bladder. So the minute the patient pees first thing in the morning, it's going to look red. And remember, I've talked about this now in several lectures. The blood may look red, right? And on the dipstick, it'll be positive for blood. But if I actually did a UA on these patients, as long as they don't have any other like underlying kidney disease, their UA is going to be negative for red blood cells or have very few, right? Hemoglobin, myoglobin, and red blood cells will all screen positive for blood on the dipstick because the dipstick can't tell them apart. But if we did the UA, hemoglobinuria is not going to be positive for red blood cells because it's just the heme, okay? And then we can see like chronic hemolysis too. So the reason these patients can be pancytopenic too is because the CD55 and CD59 are also found on white blood cells and on megakaryocytes or platelets, right? So we can get complement destruction of those. You can also get infiltration of the bone marrow is known to happen too. We get bone marrow hypoplasia due to this disease. And then we'll put into this thrombotic pattern too, which is just, it makes for just a very, very odd presentation where we have the pancytopenia, hemolytic anemia, thromboses, and then this dark colored urine, especially early in the morning. We can use things like eculizumab, which I talked about in my MAHA lecture. It's also used for atypical hemolytic uremic syndrome. It's a monoclonal antibody against proteins C5. Okay, ravulizumab is a long-acting C5 inhibitor. We should give vaccination against Neisseria meningitidis. That's required before starting a patient on a C5 inhibitor. Because remember, C5 through C9 makes my MAC complex, and MAC is super duper important to get rid of Neisseria, right? It cuts a hole in Neisseria and a lot of my other bacteria, but Neisseria especially, cuts a hole into it, causes destruction, right? So I start thinking about terminal complement deficiency when I see a patient who's had 2 or more episodes of Neisseria meningitidis meningitis. I've talked about that in other lectures too. We can do supportive care with folic acid, iron, and RBC transfusion, and then we can do stem cell transplant, which is the only effective cure. So high yield points, right, is the only acquired hemolytic anemia with an increased risk of thrombosis. The thrombosis often occurs at atypical venous sites. To diagnose it, right, classic step 2, we do flow cytometry for CD55 and CD59. It's associated with aplastic anemia and acute leukemias. And then C5 inhibitors improve survival, but we need to prophylactically treat for meningitis with the vaccination. Okay, Neisseria meningitis specifically. All right, almost there. Heparin-induced thrombocytopenia. So this is classically going to occur 5 to 10 days after starting heparin. Classically more unfractionated heparin rather than low molecular weight heparin. We may also see thrombocytopenia, and actually we have to see thrombocytopenia with a drop of more than 50% in platelets in order to further like actually diagnose this. We'll probably see new thrombosis too. We'll see DVT, PE, and arterial events. We may see some skin necrosis at the injection site after or like these acute systemic reactions after giving heparin. So again, I'm going to look for a patient who was put on heparin 5 to 10 days later. They have a drop of more than 50% in their platelets, and they have thromboses. Okay, and we'll talk about why. So again, labs, we're going to see the platelet count dips by more than 50%. We'll do a functional assay like the serotonin assay is the serotonin release assay is the gold standard. Okay, so if they're asking you on step 2, how do we definitively diagnose it? Serotonin release assay. We could do immunoassays like the PF4 heparin ELISA antibody test, which is a good screening test, but it's not the gold standard. And then the coagulation tests are usually normal. So the pathophys, heparin is always going to bind to this platelet factor 4. Always binds to platelet factor 4, forms a complex. We get ourselves into trouble when our immune system recognizes that complex as abnormal. It forms IgG antibodies against it, and then the IgG antibodies attach on to this heparin platelet factor 4 complex. That then will lead to the overactivation of platelets. So that complex, the heparin platelet factor 4 plus the IgG, causes overactivation of platelets, okay? It binds to the Fc receptors on the platelets and causes activation. So all my platelets get activated and they form huge clots, right? It's a consumptive coagulopathy, but we're just talking about platelets here, not the clotting factors, right? So this should ring a lot of bells if you watch my MAHA lecture. It's kind of similar. So we activate the platelets, they form a lot of clots, so we get all these thromboses, but then we've used up all of my platelets, so now I have thrombocytopenia, right? So it's kind of that paradoxical reasoning we've talked about in the MAHA lecture. So the heparin platelet factor 4, IgG comes and binds, that activates the Fc receptors on the platelets get overactivated and form a bunch of like clots and thrombosis, but we've used up all of my platelets, so now we get thrombocytopenia. Again, we've talked about this. To manage, there is something I'll just say really quickly. There's the 4T score. You can easily look it up on MD Kelp, but basically it's we look at the timing, right? Does this fit? That's the first T. Does this fit the 5 to 10 days? We look at the thrombocytopenia. Did the platelets drop by more than 50%? We look at thrombosis. Is there some sort of thrombotic event? And then the fourth T is other, right? So they just like capitalize the T as a second letter, which is stupid, but did we rule out other causes? Okay. So that's a 4T score, and it can give you like a prediction, like this is the likelihood that this is hit, or it's probably not hit. You should look elsewhere. All right. Management, we stop all heparin products immediately. Always the right answer on the exam if they haven't done that. We start alternative non-heparin anticoagulations. Our Gatroban is usually the first line. We can use bivalirudin or fondaparinux. We avoid warfarin until the platelet count recovers because we don't want warfarin-induced skin necrosis. Don't re-expose heparin in the future. And again, I just wanted to remind you, the serotonin release assay is the gold standard. So again, high yield points, it's a paradoxical thrombosis with the low platelets. We suspect it if the platelets drop after 50% with after 5 to 10 days of giving heparin. Type 2 hit is the immune mediated that I talked about. Type 1 is more of a mild non-immune. It's not super clinically relevant. We're not going to talk about it. Platelet transfusion is contraindicated unless life-threatening bleeding occurs. That's because we have all these complexes against activated or that activate platelets, and it's just going to cause things worse. So we've got to be really careful with the platelet transfusions. All right. Antithrombin 3 deficiency, again, we've kind of talked about this, but it presents with recurrent venous thromboembolism, thrombosis at a young age, a strong family history of thrombosis. Thrombosis can occur at unusual sites, kind of like PNH, so cerebral or mesenteric veins. It can be acquired. We talked about nephrotic syndrome or liver disease, right? Because antithrombin 3 is going to be made in the liver, or it can be inherited. So again, we'll have a normal PT or PTT unless we're tested in the presence of heparin. We'll have a reduced antithrombin activity assay, because we're missing antithrombin 3. Heparin resistance is really the hallmark of this disease. So normally when I give heparin, we activate antithrombin 3, we block factors 10 and 2, the PTT prolongs, okay? If my patient has antithrombin 3 deficiency and we give them heparin, there's nothing for heparin to activate. So there's nothing that's going to stop factor 10 and factor 2. So the PTT is not going to prolong, okay? We can do an antithrombin antigen level that may help us differentiate type 1 versus type 2. Not important for USMLE step 1 or step 2. Pathophys, again, antithrombin 3 normally inhibits thrombin and factor 10, which suppresses coagulation. If we have a deficiency, we get unchecked thrombin activity, right? Thrombin cuts fibrinogen to fibrin. We make more of these networks of fibrin meshes, and we get more clots, right? Type 1 is a quantitative deficiency. Type 2 is a qualitative deficiency. The heparin mechanism becomes impaired, like I said before, so we get heparin resistance. Management, obviously, it's going to be the same as whatever I've talked about before. So we initiate anticoagulation. We can give antithrombin concentrate, right, if they're missing it. We can do lifelong anticoagulation and then avoid risk factors. Being an inherited antithrombin 3 deficiency is extremely rare. It's the only inherited thrombophilia with this heparin resistance, right? Given the mechanism, right? We lose antithrombin 3. That is the whole mechanism of heparin. Heparin is supposed to enhance and activate antithrombin 3. If we don't have antithrombin 3, heparin can't work. Acquired causes, the big ones, you want to think about nephrotic syndrome and liver failure. We've talked about both now. It does not affect routine coagulation labs, and we should suspect it at some point if we have a young patient with venous thromboembolism unresponsive to heparin. All right. Protein C and protein S deficiency, we've actually kind of already talked about these two. So we again could see venous thromboembolism. It may cause the warfarin skin-induced necrosis, which I've talked about already. We could see a family history. And then homozygous protein C deficiency in neonates can cause this purpura fulminans, which will basically present like DIC. Okay, I've kind of already talked about that when I talked about warfarin-induced skin necrosis. So labs normally normal, PT and PTT, a decreased protein C or protein S. Protein C may be reduced physiologically in pregnancy and OCP, right? So that's a physiological cause of decreased protein S. And then remember, protein C and protein S are vitamin K dependent, so they're reduced when I have a patient with liver disease or warfarin therapy. So the pathophysiology, so protein C normally inactivates 5 and 8, and then protein S is its cofactor, right? So without those, again, it's kind of like it's the same outcome as factor 5 Leiden. For factor 5 Leiden, factor 5 is like FU, protein C and protein S, you're not stopping me. In protein C and protein S deficiency, we just don't have the protein C and protein S to stop factor 5 and factor 8. So factor 5 and factor 8 just keep going and going and going. Management, right? Same idea. Anticoagulation. We do a heparin bridge is essential if warfarin is used because we don't want that warfarin-induced skin necrosis that we've talked about. We consider lifelong anticoagulation. And for the neonates with the purpura fulminans, they'll require protein C concentrate or fresh frozen plasma. So again, the high yield points, this increases the risk of venous thromboembolism. It can lead to warfarin-induced skin necrosis. Protein S deficiency can be physiologic in both pregnancy and estrogen, and protein S is that cofactor for protein C. We always want to evaluate the protein C and S levels after stopping warfarin, okay? And then homozygous forms present with severe neonatal thrombosis. All right, just two more real quick on homocysteine. Homocysteine, when I think about elevated levels that are inherited, they may begin in infancy with developmental delay. So elevated homocysteine can cause developmental delay. These patients also classically have a marfanoid habitus, and psychiatric and behavioral disorders. So remember, marfanoid habitus is not always just Marfan syndrome, right? Off the top of my head, right, we have Marfan syndrome, we have elevated homocysteine, so homocystinuria, and there's even marfanoid habitus and MEN2B syndrome, okay? The MENs will be its own lecture because that's also really high yield. We'll see a history of thromboembolic events. The patient's lenses in elevated homocystinuria inherited classically are downward dislocated, whereas in Marfan syndrome, the lenses are classically upward dislocated. We could see osteoporosis too, because these patients tend to have very weak bones. The family history is consistent with an autosomal recessive. So labs will see elevated homocysteine. The sodium nitroprusside urine test will turn red in the presence of homocysteine. So the nitroprusside reacts with the thiol of homocysteine and it will turn the patient's urine red. Keys me in on this diagnosis. We'll see elevated methionine in this cystathionine beta synthase deficiency, and we'll see low methionine in this MTHFR deficiency. So these are the two major causes I'm talking about here. So again, this is an inborn error of metabolism. So the pathophys, if we have a cystathionine beta synthase deficiency, the methionine builds up, but we're never able to turn methionine into, or where the homocysteine builds up and we'll make more methionine, but we're never able to break down the homocysteine. All right. With the MTHFR, we could see potentially low methionine levels. Here's exactly like what's going on, right? So it's a defective conversion of homocysteine to cystathionine or to methionine. So again, the patient has elevated they have homocysteine. Homocysteine should be broken down to cystathionine or methionine, right? We're going to throw homocysteine through this CBS enzyme, and that should make cystathionine. Or we'll throw homocysteine through this MTHFR enzyme, and it will make methionine. If either one of those enzymes are deficient, homocysteine has less paths to go through, and it will build up. Okay, so that's why the methionine will be elevated in the CBS deficiency, because homocysteine is not able to get broken down to cystathionine, so it has to go down the methionine route. And that's why methionine is low in the MTHFR deficiency, because homocysteine can't go the methionine route, it has to go the cystathionine route. All right, this leads to toxic accumulation of homocysteine and vascular endothelial damage. Management, we can treat with B6. I'll show you why on the next slide. We'll use a low methionine, high cysteine diet in CBS deficiency. We'll supplement with folate and B12. We can use betaine, which is the methyl donor, which actually has proven to impact outcomes with homocystinuria. And then we can also do long-term anticoagulation. So some high yield points, again, remember, homocystinuria will have the marfanoid habitus intellectual disability with lens dislocation down and in, okay, versus up and out in Marfan. It's associated with arterial and venous thrombosis, MI, stroke. It's part of the newborn screening pattern in many regions. And then I'll talk about B6, B12, and folate on the next slide. So acquired elevation in homocysteine, right? Again, same idea, so I don't really need to go into it, but it's an increased risk in patients with poor nutrition, alcoholism, malabsorption, or renal failure. We'll see elevated total plasma homocysteine. They may have elevated levels of B6, B12, or folate. The MMA levels may help differentiate B12 from folate deficiency. Remember, MMA is going to be elevated in B12 because B12 is a cofactor to help break down MMA. If I don't have B12, the MMA stays elevated. Genetic testing, usually not indicated. The pathophys, homocysteine is metabolized exactly as I said before. We remethylate it to methionine, which requires B12 and folate. We do transsulfuration to cystathionine, which requires B6. So if I'm missing B12 or folate, we can't convert homocysteine to methionine, so homocysteine builds up. If I'm missing B6, we can't convert homocysteine to cystathionine, so homocysteine builds up. Again, homocysteine causes endothelial dysfunction, oxidative stress in this prothrombotic state because it increases factor 7, factor 5, it decreases protein C, it increases blood viscosity, and it decreases endothelial and anticoagulant function. So management, we treat the underlying vitamin deficiencies. Folic acid is always first line. It's the most common cause, so replace their folic acid. We'll give them vitamin B6 or B12 if they're deficient, and we try to encourage them to reduce their risk factors like smoking, dietary modifications, alcohol. So again, homocysteine that's acquired or elevated homocysteine that's required. It is the most common acquired cause of homocystinuria or homocystinemia is going to be folate deficiency. It is an independent risk factor for vascular disease if they have elevated homocysteine levels. It's usually seen in elderly, vegans, or malabsorptive disorders where they're not able to get those vitamins in. We evaluate homocysteine in young patients with stroke or thrombosis. We should think about it, and it responds very well to vitamins therapy, especially folate. All right, that was a whole lot. We're going to put it together with one final question, and then we'll be done. We have a 32-year-old woman presents to the emergency department with acute onset pleuritic chest pain and shortness of breath. She reports that the symptoms started suddenly 3 hours ago while she was at work. She has noted that her right calf has been relatively sore and more swollen over the past 2 days. She has a history of 2 first trimester miscarriages and 1 second trimester fetal demise. Her only medication is a combined oral contraceptive pill. She does not smoke. Vitals are as shown. She's afebrile. Her BP is 110/68. Heart rate's 110. Respiratory rate 24. O2 sat 91. On exam, she appears anxious and tachypnic. Lungs are clear to auscultation. Her platelet count is 120. Her PTT is 45. Her INR is 1. She's not pregnant. Her VDRL is positive. And I want you to think about which of the following is the most likely mechanism responsible for this patient's underlying condition. So pause your screen, think about what disease you think is going on, and then which of the following of these pathophysiologies match up. So this is definitely antiphospholipid syndrome. So hopefully you caught on to that. I didn't give you the positive like lupus anticoagulant or beta-2 glycoprotein or anticardiolipin. And honestly, like USMLE probably won't either. You're going to have to kind of like reach for it. Things that gave it away were the elevated PTT. Remember, I told you thromboses with an elevated PTT should always key you in on APLS. This patient also had a positive VDRL, which may or may not be due to anticardiolipin causing a false positive. Maybe she does have syphilis. That's not important for this case, but the positive VDRL with an elevated PTT in a patient who's clotting really keys me in, especially with this OBGYN history we've got going on here. The pathophysiology, the autoantibodies bind to beta-2 glycoprotein, which adheres to negatively charged phospholipids on the endothelial cells, the monocytes, and the platelets. That upregulates adhesion molecules, which promotes expression of tissue factor, factor 3, which initiates the extrinsic clotting pathway. The endothelial cells shift into this procoagulant phenotype. It reduces the production of nitric oxide and prostacyclin, which are both vasodilatory and antithrombotic. The antiphospholipids themselves, this whole process is going to also impair protein C activation, which we know is really important to stop the clotting cascade. And then there's reduced thrombomodulin expression, which further impairs the activation of protein C. All in all, we are thrown into this super hypercoagulable state, but in vitro, the antiphospholipids bind to the phospholipids that are needed to kickstart this test in vitro, so the PTT is prolonged again. My last question for you, I'm going to do a whole lecture on Wells score. It'll be like a quicker one, but I want you to see if you can calculate this patient's Wells score based on this. So I'll go through it in a second. So pause your screen, reread their vignette, and come up with their Wells score. So when I look at Wells score, right, I have it memorized. I think it might be worthwhile to memorize it for USMLE and just for like the rest of your life, right? I break it down into 3 different categories. There's 2 things that give me 3 points. There's 3 things that give me 1.5 points, and then there's 2 things that give me 1 point. So the things that give me 3 points are, does the patient have clinical signs and symptoms of a DVT? Absolutely, right? This swollen and red calf, that gets me 3 points. Is a PE the most likely diagnosis? In my mind, yes, for this one, right? She's got pleuritic chest pain. She has tachypnea, tachycardia, and hypoxemia. Classic, right? So I'm thinking PE with the DVT. Likely, I'm thinking classic PE, so that gets me another 3 points. The things that give me 1.5 points are tachycardia. She gets 1 there, so we're already at 7.5 points. The other 1.5 points would be things like, was she immobilized for more than 3 days? Or did she have surgery in the last 4 days? No to both of those. The last thing that gets me 1.5 points would be, does she have a past medical history of DVT or PE? She doesn't, at least not that we know of, so no points there. And then the two things that give me 1 point are hemoptysis. Is she coughing up blood? Nope. Does she have a history of malignancy treated in the last 6 months? Nope. So she's stuck at 7.5 points, which is well above what I need to die, like to be very suspicious of a PE. Right. So I showed you the calculator here. When I see a score greater than 6, that's immediate indication we should put the patient on IV heparin as long as they don't have any kind of contraindications, and we should go get a CTPE. Obviously, if the patient was pregnant or had underlying kidney damage, we should do a VQ scan as instead, because we don't want to give them radioiodine contrast. I will talk all about this in my well score lecture. I just thought it would be a good like primer to think about. All right, we covered an absolute huge amount of information. Hopefully this helps clear up some of the thrombophilias. We covered all of that in less than in an hour. So I think that's pretty good. If you have questions on this lecture, please email me and tell me what topics you want me to cover. Otherwise, until next time.